these rates are 25 times greater than the general population, and that is very representative of the international picture. But there is a perception out there that this excess liver mortality is a consequence of Hep C infection alone. But that perception is at odds with an epidemiological evidence base that suggests that alcohol is a really important accomplice, a really key and critical contributing factor. So, in the course of this presentation, I want to take you through what that evidence is in a very broad overview of it. So the first port of call is to examine what infected persons drink. And we have two sources of data that can assist us with this question in Scotland. Firstly, there are surveys of people who inject drugs conducted regularly in Scotland. That's PWID for short. And what we know from these surveys is that 22% of infected PWID report drinking more than 50 units in the 7 days prior to the survey interview. The equivalent statistic for the general Scottish population is 4 to 9%. We also collect data on infected individuals attending specialist care in Scotland. And we know from this that about a third of patients report a history of ever drinking more than 50 units a week for a sustained period of time, at least 6 months or more. This issue of heavy alcohol use in infected populations is not idiosyncratic to Scotland. The same picture emerges elsewhere, and here we can see that statistics for the US are quite comparable to Scotland. So heavy alcohol use is associated with liver disease progression and also liver mortality. But what does this mean when we say that there is an association present here? Well, let me illustrate with a particular case study of our own. We previously collected data on 1,600 individuals newly attending a liver clinic in Scotland. And we broke those 1,600 patients down into two groups. Those that reported a history of heavy alcohol use, that's drinking more than 50 units a week for at least 6 months, and those that did not. We equivalized those two groups in terms of factors such as age, gender, and deprivation. These are factors that also have bearing on, also have an influence on one's health. And we compared the frequency of liver cirrhosis at the time of first appointment. And what we found was very much as you would expect. In the Hep C plus alcohol group, liver cirrhosis was far more common than in the Hep C no alcohol group. So the odds of liver cirrhosis in the Hep C plus alcohol group was 5 to 1, whereas it was 17 to 1 in the no alcohol group. And based on the size, based on the difference in odds between these two groups, and also using the prevalence of heavy alcohol use, we were able to calculate that in this population at this time, 36% of all liver cirrhosis cases would not have occurred had the patient not engaged in heavy alcohol use. This is a big talking point in Scotland, and David will come on to speak about this. The number of Hep C patients with new onset liver failure is increasing in Scotland and increasing fairly rapidly. But what is often not mentioned is that 40% of these liver failure cases, the presiding clinician has explicitly listed alcohol as a primary or contributing cause. But alcohol consumption is notoriously difficult to measure, and it's preferable to have a diverse evidence base that doesn't rely completely on what people tell you they're drinking. Fortunately, the natural history of Hep C infection affords us something of an alternative. When when a group of individuals are exposed to the Hep C virus, about 3/4 go on to develop chronic infection. So that's persisting infection that lasts indefinitely until treatment. But the remaining quarter clear this infection spontaneously of their own accord, with short duration, 2 to 3 months. For the epidemiologist, there is an opportunity here. There's an opportunity here to perform a certain type of natural experiment, because these two groups, by virtue of both coming into contact with the Hep C virus, are likely to be similar. Not identical, but broadly similar in terms of lifestyle factors and heavy alcohol use. So on that basis, any difference you see in the liver mortality rate between these two groups here should be entirely attributable to Hep C, chronic Hep C infection. So let me illustrate this with a hypothetical example. Let's suppose we have a group of chronically infected individuals of a particular age, gender, demographic, and let's say we observed a liver mortality rate of 10 deaths per 100 person years. Interesting and informative, but only to an extent, because it tells us nothing about what fraction of this death is actually due to chronic Hep C infection. But then let's say that we had some data on spontaneous resolvers of the same gender and age demographic. And let's suppose we observed in this group that the liver mortality rate was 2.5 deaths per 100 person years. Well, assuming that lifestyle factors, heavy alcohol use, is comparable in these two groups, then you can infer that in this chronic group, 25% of the death would have occurred anyway, 75% would not. So in other words, 75% would be attributable to chronic Hep C, and 25% would not be attributable to chronic Hep C. So that's the principle, and we performed these very same calculations for Scotland and for Denmark. In fact, Scotland and Denmark are the only two countries in the developed world that have the requisite data to perform this analysis. And what did we find? Well, we found that 55% of deaths in Scotland, liver deaths, could be attributable to chronic Hep C. And in Denmark, that was slightly higher at 68%. So the flip side of that, of course, is that 45% and 32% of liver deaths could not be attributable to chronic Hep C, and presumably reflect lifestyle factors, of which heavy alcohol use would be the prime suspect. There is limited information on how common liver disease is after attaining a sustained viral response. But we do have some very initial data from Scotland. So we found that in a cohort of 560 patients attaining SVR, we found that the subsequent rate of liver-related hospitalization remained quite high, at about 10 times that of the general population. And even when we excluded those SVR patients who had liver cirrhosis, hospitalization still continued to be 6 times more common than the general population. And because these SVR patients have cleared the Hep C virus, this begs the question as to what is causing continued excess. And alcohol, again, would be a really credible suspect here. But we need more data on this issue before drawing any firm conclusions. So let me try and wrap up now everything we've covered into a single epidemiological thread. Heavy alcohol use is common in individuals with infection, and a lot more common than that of the general population. Heavy alcohol use is associated with liver cirrhosis in Hep C patients, and we calculated that 36% of liver cirrhosis cases present at the time of the first specialist appointment wouldn't have occurred in the absence of alcohol. Hep C new onset liver failure cases are rising, but in 40% of these cases, alcohol is listed as a primary or contributing factor. When we use spontaneous resolvers as a benchmark group, this analysis suggests that 45% of liver deaths in chronic Hep C patients would have occurred anyway, regardless of chronic infection. Then after clearing the hepatitis C virus through treatment, there is an early indication that liver-related morbidity remains high. So let me summarize with a brief afterword. The epidemiological evidence that I presented here thus far has not been translated into any significant public health action. In fact, there have just been one handful of studies exploring the impact of an alcohol intervention in patients with hepatitis C. My own reading of the evidence is that elevated liver mortality in this population is a compound problem. It's a compound problem and it requires a compound solution. So that means antiviral therapy plus something equals a reversal of mortality excess. Hopefully, over the course of today, we will be able to hone in on what the missing part of this equation is. Thank you very much for your attention. Just like to briefly acknowledge Professors Hutchinson and Goldberg, colleagues from Health Protection Scotland and ECU, members of the Clinical Database Monitoring Committee and data entry staff on those systems.